Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors, Pfizer, Ipsen, and Recordati, and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, please feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar, Pituitary Centers of Excellence, Multidisciplinary Care for Pituitary Patients, is presented by Dr. Gardner, Dr. Zenonos, Dr. Fazeli, and Dr. Mahmud. Please hold as there will be a brief delay while we change presenters.
In this talk with two of my excellent collaborators. Unfortunately, my neurosurgical partner, Dr. Zenonos, is not able to be here this evening. But I think this is a particularly important topic that we're going to be discussing here, and that's pituitary centers of excellence. I think this is very important for pituitary patients and for pituitary care in general. And the plan is just to give sort of a brief overview of centers of excellence, and then for us to talk through some cases, sort of show you a bit how it works in our particular center. Let's see if these are changing for you. There we go. So a pituitary center of excellence, you might say, well, what exactly is that? What's the definition of a center, of any center of excellence? Well, this is a team of physicians, nurses, medical professionals, researchers, etc., that are working together with one common goal. And it's most commonly, this is designed as multidisciplinary care. And you see here the different aspects that are involved with managing pituitary surgery and pituitary tumors. I'm sure many of you have come in contact with many of these aspects, some of which are up front and some of which are behind the scenes. Here's our particular center of excellence, and you can see there with neurosurgery, there's myself and Dr. Zenonos, and then our endocrinologists who are neuroendocrinologists, pituitary specialists, Dr. Pouneh Fazeli and Dr. Hussain Mahmud. And then you see our ophthalmology team. We have a full neuroradiology team that reads all of our films. We have a research coordinator. We each have nursing teams on both the endocrinology and the ENT and neurosurgery side. You see two of our radiation experts there, and then our expert ENT surgeons who work with us for all of these surgeries. And this entire team is involved with every single pituitary patient to provide them the highest level of care, really a subspecialty team. There's been a tremendous amount of progress in pituitary surgery, and most of that is based from a surgical standpoint or technical standpoint on endoscopic endonasal surgery. This combined with the advances in medications that have happened over time and treatments have really revolutionized the treatment of pituitary. Now here's just looking at the incidence. As all of you know, this is very common. Pituitary tumors are incredibly common, really potentially one of the second most common tumors in the head. And it's well known or well established that higher volume centers and subspecialty centers have better outcomes. Here you can see the outcomes when you look at, for example, even mortality in that bottom slide for both the surgeon and a hospital. The higher the volume, the lower those rates are. So very important correlations. The more you do of something, the better you are at it. This is probably no surprise. Here are some self-identified pituitary centers of excellence, those who meet certain criteria. And you see ourselves in red. And here's our pituitary center of excellence. And this is a dedicated team, as I mentioned. We've done actually over 4,000 endonasal surgeries now, and we do around 100 pituitary surgeries per year. Here's some of our published data and outcomes. Just the various different tumor types and aspects of pituitary that we have published and researched on. Interestingly enough, we have created metrics because we were fortunate to be able to team up with our insurance company to create, to my knowledge, the first official center of excellence recognized by an insurance company and a healthcare provider. And we have set certain metrics that we have to meet and that we check, we have to report every yearly, and frankly, we check every month. So here you can say there's a certain period of time, and length of stay is not a matter of people not wanting to have patients in the hospital. It's a matter of, it's a reflection of how well someone's doing. We look at, whether all of the different complications that we might have with pituitary surgery are looked at very closely, and then you'll see at the bottom 2 areas of quality of life that we're tracking on all of these as well. Very important. We do all this through a dashboard. This is an electronic dashboard through our medical record that can harvest all of this data for us, so we can constantly be checking on our progress and how we're doing, and to make sure that we're meeting these targets. In addition, we do separate tracking of all of our surgical cases. This is looking at different aspects for all of our surgical cases that's monitored separately. We're going to go through this really by starting with a case that we're going to discuss here among our group. I believe, Dr. Fazeli, this is your patient, I think. I don't know if you wanted to start by telling us about them.
Sure. This is a 61-year-old man with a history of chronic obstructive pulmonary disease, diabetes, sleep apnea, and a history of kidney cancer, who had a nephrectomy in 2018. And he was referred by an outside endocrinologist because the outside endocrinologist suspected the patient had acromegaly. Now, I have to give many kudos to the PCP of this patient, who, after noticing the patient's enlarged nose, checked an IGF-1 level, and it was found to be elevated, and referred him to an outside endocrinologist. The outside endocrinologist did a CT scan of the head of the brain, and that showed a partially empty cella. And the reason the outside endocrinologist chose to do a CT scan was the patient was having difficulty lying flat for long periods of time, and so an MRI was not possible. So because the CT scan showed an empty cella, he was referred to us for further evaluation. So on review of systems, the patient didn't report a change in shoe size or hand size, which you might expect with someone with acromegaly or with an elevated IGF-1 level, but did report joint aches and snoring, and was on CPAP for his sleep apnea. He did note a 60-pound weight gain over the last 3 years, as well as difficulty sleeping, and as I mentioned, had difficulty lying flat. And also had a history of recent nocturia. He was getting up 2 to 3 times a night to urinate.
What do you make of the lack of increase in the size of hands and feet, and not having all of the typical symptoms?
So I think that's an excellent question. And again, I give a lot of credit to the PCP, because what we'll see on imaging is that it seems like this was found very, very early. Most of the time, 75% of the time, by the time acromegaly is diagnosed, it's a macroadenoma or greater than or equal to 1 centimeter in size. And what we'll see with this patient was that it seems to have been diagnosed very early. So it may have just been early in the course of the disease.
It's interesting. I rely on the two of you very heavily to help understand some of these aspects of the hormone changes, because as a surgeon, if it's very obvious, then it's a little more straightforward. But there are so many subtleties with hormones that I really rely on you very heavily to tell us exactly when something is off in one direction or other. It's not that simple always. Here are the lab work, I guess, that was sent initially.
Yes. So the lab work, the testosterone level was mildly depressed, although this wasn't an early morning level. And you can see the IGF-1, which is the screening test we used to diagnose acromegaly, was quite a bit elevated. It was 674 nanograms per milliliter, and normal being up to 279 for this patient. He also had a cortisol level checked that was low. Again, this wasn't an early morning level. We repeated it. It was still low when it was an early morning level. So we did what you can see at the bottom is an ACTH stimulation test to ensure that the patient was not adrenally insufficient, and he passed the.
And that's an appropriate stimulation there?
Yes, yes. So he his post-stimulation cortisol was greater than 18 micrograms per deciliter. So he did stimulate appropriately. So we were confident going into surgery that he did not have adrenal insufficiency.
And Dr. Mahmud, why is that so important for us going into surgery to have that information?
Absolutely. So people who have adrenal insufficiency are more likely to crash during the surgery. They are likely to become more sicker. Anesthesia complication rates definitely go up. So definitely knowing that beforehand is very important. Obviously, we want to know what we did during the surgery and compare the outcomes as well. So that's the other reason to know what we are dealing with.
Yeah, a lot of workup goes into these. That's for sure. This is just a quick, overview of acromegaly. It just simply means acro. It refers to hand, and megaly, of course, is large. And there's a picture of Andre the Giant. He's one of the famous acromegalics, and he obviously is taller because he developed his tumor before he had stopped growing, before his growth plates had closed. This, I think, is the MRI of our patient, isn't it?
Yes, yes.
And this is pretty subtle, yeah.
Yes, it was done under general. So we arranged in coordination with your office to do this under general anesthesia so we could get a very accurate assessment.
Yeah, and we can see what's called an empty cella in that you see this crescent shape here of the pituitary, which normally is a little more plump and round. We sort of talk about it like a chickpea, and I quote, empty cell is when you start to see it hollowing out, and that can actually be somewhat normal, especially someone gets older. But here on this side, very subtly, we can see really a very small area that's not as bright as the rest of the pituitary, and I think that became our target then for treatment. What do you discuss with the patient in advance about what options they have for treating this?
Dr. Mahmud, would you like to take this?
So surgery is obviously the best choice for acromegaly. We have medical options, but they tend to be expensive. They tend to be predominantly injection-based, a lot of side effects, a lot of complications from those medications. So surgery is obviously the first route. There are people who are super sick, who have bad obstructive sleep apnea, congestive heart failure. So you might want to normalize their growth hormone levels beforehand, improve their in order to improve their operative outcomes. And so sometimes we will offer a neoadjuvant kind of somatostatin receptor ligands as one of those therapies. But in this case, I think surgery, proceeding with surgery would be probably the most prudent choice.
Okay. Here's just a short video. Hopefully people don't mind a surgical video here, but we have an overview, just like we saw on the MRI. Here's the pituitary. Here's actually the carotid artery on the right side, and here's the gland itself. And we get an idea on that right side that we were seeing that here might be the tumor. This is actually a case of Dr. Zenonos, where he's doing it. And here you can see the different areas that are labeled. And we do a lot of techniques during surgery that we've helped develop. Here's using fluorescence in this case to be able to evaluate, tell the difference between tumor and normal gland. And here you can see, as soon as we open the lining of the pituitary, the dura, the tumor really starts to come out. It's relatively soft, and sometimes they're like this. Now, we try usually to be able to dissect it free, but here you can see it comes out really quite nicely. Now, one of the issues is this is the lining between the carotid artery and the pituitary gland, and we've actually found that this area quite frequently is a source for residual tumor or regrowth. And sure enough, as soon as we start to peel away this lining, we start to see a little bit of subtle amount of tumor within it. We found actually about when a tumor touches it, especially a functioning tumor, a tumor that makes hormone, when we remove this wall, this thin wall, that about 85% of the time, it actually has tumor in it. So removing that little wall, I think, prevents the tumor from coming back. It helps save us from recurrence of the tumor. And this is something that's really relatively new and revolutionary, because previously it was not felt probably to be safe to do this and to remove it. And here, you know, one of the things that's really critical is, you know, we've spent a lot of time honing our surgical craft, but in the same way, Dr. Mahmud and Dr. Fazeli have spent a lot of time honing their ability to understand the hormonal aspect of things. So we rely on them very heavily to provide that. So here's some of the postoperative testing that we got. And can you sort of help us walk us through this a little bit, help us understand what we're testing and why we're checking it and what it means?
Absolutely. So I think I will add one thing to what Dr. Mahmud said about counseling patients. I've had a number of patients who have wanted to be treated with medical therapy and have had shrinkage of their tumor to the point where you don't see a tumor on MRI. All of them are still on medical therapy though. So I think surgery gives these patients the best chance of a durable remission and to be off of medications. And what you can see here is the post-op day 1 growth hormone level is low. It's less than 1 nanogram per milliliter, but it's quite a bit lower than that. And that is a very, very good sign of remission. And we do have a more recent IGF-1 level. This patient is about 3 months out from surgery now. His IGF-1 level is now normal. I think another important hormone that we measure on post-op day 1 is the cortisol level. So the cortisol level being robust, being above 15 micrograms per deciliter, tells us that the patient's hypothalamic pituitary adrenal axis is intact and that he has good adrenal function, and the pituitary is sending the signal to the adrenal glands, and that was not affected by the surgery. So that's another important hormone that we measure on post-op day 1.
A huge impact on quality of life if there's hormone function loss, that's for sure. Here's yet another case that we had. I think, was this one yours, Dr. Mahmud, or is this still, I think I don't remember. This might be this is our patient who's had a long-standing period of having sinus problems, and so finally got head imaging by an ENT specialist.
Yes, I've been following along with it. And so he was seen by an ENT specialist and had brain imaging, and the MRI showed a pituitary lesion. So he was seen by an endocrinologist within our system at UPMC Cumberland. And what was noted was that he had an elevated cortisol level. So she checked an early morning cortisol level, and it was quite elevated. But he reported being on hydrocortisone injections, joint injections, because of arthritic pain. So that can challenge our ability to diagnose somebody with cortisol excess, because the hydrocortisone from the injections may get picked up in the cortisol assay. So how do you
deal with that?
So it's very, very challenging. Dr. Mahmud, I think you might agree that these are the most challenging cases to diagnose when we're worried about Cushing's.
Absolutely. You just wait it out and try to avoid more steroid injections, and then reevaluate them when you think that steroid is out of the system.
How long does that often take?
2 to 3, can take up to 2 to 3 months.
Wow.
So he stopped the joint injections and had a normal urine-free cortisol, which is one of our screening tests for Cushing's, but had abnormal late-night salivary cortisols, which are another test that we use to screen for Cushing's. So there are 3 tests that we can use as first-line tests to screen for Cushing's, and he had elevated late-night salivary cortisols as well as an elevated dexamethasone suppression test, which is the 3rd test that we use to screen for Cushing. So 2 out of 3 were elevated, although we were still not sure that the hydrocortisone had worn off from the injections. He also did not appear like someone who might have Cushing. So he had been intentionally losing weight, 50 to 60 pounds in the last 2 to 3 years. And usually what we see in people with cortisol excess with Cushing's is weight gain. So this was puzzling. And he has the knee arthritis for which he's getting the injections, and low libido and erectile dysfunction. But otherwise, he was not reporting any symptoms. Didn't have a history of high blood pressure or diabetes, which you might expect in somebody with Cushing's as well.
Here's some more of his blood work here.
Yes, so his labs were notable for a normal growth hormone level. We checked an IGF-1 level as well as a screening test for acromegaly, and that was normal as well. His random cortisol was 8.9 micrograms per deciliter, and his ACTH level was 35 picograms per milliliter. But this was measured with an assay that has been associated with spurious elevations in ACTH levels. And so it was important when we saw this elevated, or this, I'm sorry, not elevated, but normal ACTH level, we wanted to make sure to repeat it with a different assay in order to be sure that this was an accurate ACTH level. His thyroid function test, TSH and free T4 were normal. His prolactin level, which we check in anyone with a pituitary tumor, was normal as well. And his testosterone level was normal.
I think hopefully the attendees can see how complicated these diseases can be. I deal with this every day, and there are so many of these really fine details that it's just almost impossible for me to keep up with. So I really rely very heavily on these wonderful endocrinologists to be able to understand which patients need surgery and what kind of surgery they need, because the surgery for Cushing's disease is very different. And here's the labs just showing that those continued elevations, with a new assay and everything.
Yes, so the ACTH was the high end of normal, and this was with an accurate assay. And what this told us was two things. One, that his ACTH is really normal, and that points us in the direction of ACTH dependent Cushing's if he does have Cushing's. But two, it also told me that the joint injections probably are not contributing to his hypercortisolemia anymore, because what we would expect if somebody had exogenous hypercortisolemia or a high cortisol level because of a steroid injection or some outside form of cortisol, we would expect the ACTH to be low or suppressed. And so this told us that any cortisol we were measuring now is probably endogenous hypercortisolemia. So he didn't pass his 1 milligram overnight dexamethasone suppression test. We want to see a low cortisol level, 1.8 micrograms per deciliter or less, and he had a level of 3. So that was one indication that he has hypercortisolemia. His 24-hour urine collection, which we repeated, was normal, but since and today, hot off the presses, I did get a couple salivary cortisols that are high.
Okay, so that pretty much confirms it, because and here, when we look at his imaging when he first came in, he certainly looks like he has a tumor. This, you can see a typical appearance here where the gland itself is brighter, tends to be brighter when you give contrast, and all of the rest of this is extra tissue, which we think in this case is tumor. But you might say, well, if you're going to take that out anyway, what's the big deal with all this testing? But first of all, there are things that I do very differently in the operating room. We talked about removing that wall next to the carotid artery, which is a big deal. You have to be able to do that safely, and increases the risk of surgery. So we want to make sure that we know that we need to do that. And here you see how it actually had grown maybe a little bit. But how do you do differently? How do you manage these patients differently around the time of surgery if they do have Cushing's disease as opposed to just a standard tumor? Does it even matter for that?
So they need to be monitored very closely for adrenal crisis. So that is what we expect to happen. So the tumor which is overproducing ACTH is going to cause suppression of the normal corticotroph cells, and most likely, if the surgery was successful, these people will have adrenal insufficiency within, well, that depends, but somewhere between 6 to 40, typically 6 to 48 hours later. So we typically monitor cortisol levels every 6 hours and keep a very close eye on the patients for signs of adrenal insufficiency, and wait for their cortisol levels to come down before we start treating them with steroids.
Yeah, so it could be dangerous to not know that they have this in the period after surgery.
Absolutely.
Yeah, very, very important. So that's an interesting case. So I guess that's one now that you're going to send our way, and they have a very clear diagnosis, and we know exactly what we need to do next. That's fantastic. Anything else that you think they need? I know that we, review this with the neuroradiologist at our conference, and they confirmed and told us all the things that you see here, and made us very confident about where the tumor is and what the next steps are. It looks like they're probably ready to start discussing surgery. Probably eager, I think, usually, huh?
Yes, yes. We may do some additional localization testing just to be absolutely certain before we send the patient your way that the ACTH excess or the hypercortisolemia is due to the pituitary tumor. But
I appreciate that. The more certain you are, the easier it makes my job, that's for sure. Here's another case, a little more straightforward. This was a 30-year-old woman who became very typically Cushingoid after pregnancy. So she continued to gain weight and actually developed stretch marks after pregnancy. She continued having acne and continued weight gain after surgery. And this is just an example, just to go through some of the things that we manage in a case like this. So this is the workup that you did. Can you tell me a little bit about that? So it looks like this patient had a urine cortisol and a salivary cortisol, and looks like you check a lot of different tests for these.
And often that ends up being necessary in Cushing's. Cushing's is complicated, and differentiating and making sure that we are dealing first. The first step is to confirm whether you have Cushing's or not, and the second, whether it's ACTH dependent or not, and if it is ACTH dependent, and whether it's pituitary or ectopic. So there are all these steps, which all these bridges that need to be crossed, and before the patient, we can feel confident that this patient is ready for surgery. And that testing is complicated. Sometimes you can have conflicting results, and making sense of that. This is definitely one of the hardest things we do as endocrinologists.
Yeah, it's a tremendous amount of effort, and pituitary tumors are so common that someone could easily have Cushing's from something else and have an incidental pituitary tumor or cyst or growth in the pituitary. They're incredibly common. And so just relying on a scan really isn't appropriate, or it doesn't give us the answer. So here we can see, though, now that this diagnosis has been given, we can see that there is this right-sided growth on the right side, and maybe a little bit here on the left that we're worried about. It becomes pretty obvious that we think there's something there. So this patient actually underwent surgery at another hospital and did pretty well. But the cortisol levels didn't drop right after surgery, like we talked about. They never had that crash, and you can see a hint of something left behind there. So what do we do in someone like this, where we're suspicious that they still have Cushing's disease? Do you need to repeat the workup? What kinds of things do you do in this situation?
We usually don't repeat the workup. We are pretty confident if they don't have symptomatic benefit after surgery that either most likely the tumor wasn't fully resected and that there's still tumor. So usually we recommend that they have surgery again. I think if the surgeons felt like they had gotten everything, then medical, and maybe I think this patient may have been placed on medical therapy because there wasn't an option for surgery again at the center she was at.
Yeah. How effective are those medical treatments for Cushing's disease?
At best 25 to 50% effective. So some of the, but I think the effectiveness comes with risks, or they're difficult to tolerate medications as well. And so, for instance, we have ketoconazole and metyrapone, which are two adrenal-based medications. They're about 50% effective. Metyrapone is a 4 times a day drug, and ketoconazole is a 2 to 3 times a day drug and is associated with liver function abnormalities and a risk of liver failure. And so it becomes very challenging to monitor those patients on medical therapy. So first line therapy is always surgery in these cases, because that gives the patients the best chance of long-term remission.
It is challenging, but it's wonderful that you have medication treatment options for them. Is that something that's relatively new?
Yes,
yes. Yeah.
I would say in the last 10 to 15 years, we are really lucky to have a number of new medications. There are new medications coming out now, ozolodrostat and levoketoconazole as well, and we have a glucocorticoid receptor blocker. Again, all of these have challenges. For instance, mifepristone, which is the glucocorticoid receptor blocker, has clinical benefit, but it becomes very challenging for the endocrinologist to monitor cortisol levels because cortisol levels go up with that medication. So all of these medications have challenges, but we're really lucky to have medical therapy now and options.
Yeah. Amazing variety of tools there. And so when we reviewed this, we saw that they had essentially that tumor that we showed before in that medial cavernous wall is where this tumor was, and so we thought that we could safely remove this. We felt this was the area that the tumor had regrown in, and the reason for that. And you can see here, this is how a sinus looks after it's been operated once. And here we're sort of peeling away some of the scar from the prior surgery. And one of the main things that we do is we do a wider exposure even. So a lot of the bone over that artery that we're trying to work carefully and safely next to has now been removed, and that allows us to work with two hands in that area to carefully cut away the wall of that separation between the gland and the artery. But this is a great example of how if we don't do these types of things, these tumors will recur. Certainly irradiation in the form of radiosurgery, such as Gamma Knife, is another great option for this, but these really require kind of everyone working together. Here we see a little bit of soft tumor there, but now we really have to open this area called the cavernous sinus. It's called cavernous because it's like a cave, and a sinus is not like the sinus inside your nose is, but sinus is another word for a large vein, and usually there are things like nerves, and in this case the carotid artery, that sit inside that vein. So here we can see exposing that artery, and now we can start to see this wall of the artery is much thicker than it should be. It's not that nice thin wall. This is the same material. It should look like that nice thin material we're cutting through there, but instead you can see how it's very thick and completely infiltrated with tumor. So certainly appropriate to have left that, because you have to be comfortable doing this type of maneuver to be able to safely remove it. And you can see why. You can see how it's attached to the artery. We're having to carefully cut this wall, cut the attachment off of the artery, and that's obviously a tricky thing to do, something you have to be careful and confident in doing and able to manage. And here's even a paper that we wrote about the different techniques on how to remove that medial cavernous wall to try to get the most complete treatment of this. And here, just cutting the little ligaments that we described that attach to that artery. And then you can see tumor just filling this entire area between the artery, which bulges in, and the gland on the other side. So we want to see nothing but those two things when we're done, and very carefully cutting through it. And then here's the last bit where we're using some of these instruments that we specially designed to be able to do this kind of work. And here we are peeling out that last bit of tumor. And so sure enough, we felt pretty good about this. And look how much tumor was in that wall. It's pretty incredible to me that it's not even growing in the gland anymore. It just finds somewhere there to grow. And here's just showing how we patch that up. We put a little fat in there actually in case there is radiation in the future that helps keep the gland away, because radiation can have some negative effect on the gland. So we try to keep them separated from each other. And here, this is a graph of the cortisol levels after surgery. Is this typical of what you'd expect to see, Dr. Mahmud? Is this the kind of thing that you look for?
This is what we want to see. Low cortisol levels immediately in the post-operative period are very predictive. So cortisol, there's the data for low cortisol levels under 5 and some studies cortisol levels under 2 is very predictive for long-term cure of Cushing's. So this is exactly what we want to see. And after seeing a few cortisol levels like this, we would start the patient on steroids and gradually taper them off it afterwards.
So they really need those steroids that have to be placed back on them.
Absolutely. So they do feel, these patients are very hypercortisolemic. They do need, they're used to very high levels of steroids. So we actually discharge them on higher than usual, higher than physiological replacement doses of steroids, and would only gradually taper that over the next few months. The average time duration of being able to go off the glucocorticoids completely after Cushing's disease surgery is about 1 year. So that's the median time period. So it takes a while and you have to truly do a lot of hand holding because they are feeling the adrenal insufficiency symptoms during that time, but you still have to gradually keep on tapering the steroids.
This disease has to be incredibly frustrating to go through this whole process. It takes so much testing to get the diagnosis, and then afterward, it takes a long time for the body to recover, a very long time. I always tell patients if we do our job well, they're going to feel awful after surgery. The one time I want them to not feel good, and not in any other way though. It's interesting because, before surgery, for really most of these tumors, that's when you guys really carry the majority of the workload in doing the workup, making sure that patients are safe for surgery and understanding that. At the time of surgery, it's completely out of your hands, and I work very closely then with the ear, nose, and throat doctor. And then frankly, afterward, I'm sort of a little more of an overseeing. I'm making sure there are no new neurological problems at all, and the vision's okay. But frankly, both you and then the ENT really carry the workload again after surgery for the healing of both of the nose and of the pituitary gland. So I think it's a great example of how all of these really have to work together. I'm not an ear, nose, and throat doctor. I don't know exactly how to help it heal the best. I have some ideas, but really rely on them, and just rely on you to make sure the gland is healing all right. Here's an article, an older article that really proved that if you see these cortisol levels crash, that it really predicts long-term remission of these tumors. Here's a very interesting one that we shared recently, very fascinating. This person, this 37-year-old guy came to us. He had a very large, about 3-centimeter cellular lesion, but his prolactin level was extraordinarily high, 14,000, where normal is less than 18. What does that tell you? This is a very different, this is sort of the other side of the coin, isn't it? Not really surgical disease.
Yes, so this was a patient with having such a high prolactin level with a large tumor tells you potentially that this patient will be very, very responsive to dopamine agonist or medical therapy. So it's usually not a bad sign to see a very, very high prolactin level with a large lesion, because it means that we can potentially treat the patient with a medication. And so he was initially seen at another facility and started on dopamine agonist treatment. So there are two types of medications, or two dopamine agonists that we have, bromocriptine and cabergoline. Cabergoline is a little bit better in terms of shrinking tumor and normalizing the prolactin level. He was started on that. Because of insurance issues, they switched to bromocriptine. By the time he presented to us, he was off all medical therapy. But at the time he was diagnosed with this very, very large tumor, not surprisingly, given the size of the tumor, he also had hypopituitarism. So he had adrenal insufficiency and hypothyroidism because his pituitary gland was not able to send the signals to the adrenal gland and the thyroid gland because this large tumor had taken over. And his testosterone level was also low, which we can see due to a high prolactin level or due to a problem with the pituitary. So they were waiting until the prolactin level normalized before starting him on any treatment for the low testosterone.
Okay. So how long does it usually take for a response from these tumors from this treatment?
So we usually want to start treatment with medication at a very, very low rate. So the larger the tumor and the higher the prolactin level, the more responsive these tumors tend to be with medical therapy. So we start them on a very, very low dose. And even starting patients on a very, very low dose, you can see visual improvement and tumor shrinkage right away. One of the first things that these medications do is it shrinks the cell cytoplasm. And so you can, even before you're killing off the cells of the tumor, you can already see improvement. And I've had patients who, after 1 to 2 doses of cabergoline, will tell me that their vision has improved.
Yeah, that's absolutely incredible. It's sort of almost melts it away. And here you see, actually, believe it or not, this is smaller than it was initially, but this is maybe not quite the same amount of shrinkage you expect to see. Is that correct?
So I would have expected to see potentially more, but it's hard to know we didn't know what it looked like 2 years prior, and he'd also been off the medical therapy for quite a while. He wasn't exactly sure when he stopped taking it, but over the 2 years prior, he had been pretty non-compliant with his medical therapy, but his prolactin level had come down quite a bit.
It can sort of fluctuate with the medication, huh?
Exactly.
Are there long-term effects from that medication? You know, once they're on it for a while, does it still help control the tumor a bit if they stop it, or how does that work?
So we can, I mean, if he was intermittently compliant, but it was effective at the outset, we do expect that it will be effective longer term. So we did try again.
Yeah, I mean, you can see such a big tumor like this too is not one that, you know, as much as we can do some great feats sometimes, this is really extending into areas where the odds of us getting every last bit of it are almost zero. An important piece here with a tumor this size, we sent them to our ophthalmology crew. That's one of the first steps we want to know. We want to monitor that throughout. So what's the vision before, what's the vision during treatment, and what's the vision after, to make sure nothing that we do is having a negative effect on that. Very important piece of it, and they monitor that very closely for us. We're fortunate to all have clinics on the same days, so usually we're able to line this all up and see people in a multidisciplinary fashion, which is wonderful. So you then changed the dose a bit?
So we started at a very low dose. We started at half the tablet, which is 0.25 milligrams twice a week, and slowly titrated the dose up. It was challenging because he is the primary caretaker for a 4-year-old nephew, and so he was not really compliant with coming in for follow-up. So I was titrating the dose of the cabergoline despite not necessarily having follow-up prolactin levels. We finally did get one after he was on a dose of 2 milligrams per week, which is the FDA approved maximum dose, and his prolactin level was still in the 400s. So we increased up further to 3 milligrams a week.
Wow, that's a pretty high dose, huh?
Yep. Yes.
And there you see, still hasn't quite normalized on his prolactin, but probably more importantly, he really didn't tolerate the medication very well.
So,
is that typical, or?
Well, one of the, I think, and Dr. Mahmud, maybe you can discuss this as well, but one of the things that we have come to realize probably in the last 5 to 10 years is that these medications can be associated with significant psychiatric symptoms. There have been a number of studies looking at increased impulsivity and mania, and perhaps this shouldn't have been surprising because dopamine agonists are the opposite of most antipsychotic medications, which are dopamine antagonists. So if you're adding potential fuel to the fire, if in the right person, you could have symptoms of increased impulsivity and mania. And the more I counsel patients on this, the more I pick it up and realize that these medications do cause these symptoms. We weren't doing that before. So he, over Christmas, reported to me that his family members who had been seeing him for the first time in a number of months reported symptoms of irritability and paranoia on now that he was on these higher doses of cabergoline. And this worried me not only for those symptoms, but also given the fact that he was the primary caretaker of a young child.
It must be so scary for him to be experiencing that, and it's no wonder he probably wasn't always compliant with it if he noticed these symptoms. You know, that I can certainly understand that.
Absolutely.
What do you do in this kind of scenario then? What are our options?
We seriously need to revisit surgery. So impulse control can be a major problem. These are folks who can have gambling issues. Surgery would be the next. We have to start having a discussion regarding surgery. The other issue in this person would be that this is going to end up being a chronic medication. This is a very high dose. When we are using 2 milligrams per week or higher doses, we need to start getting worried about the cardiovascular or valvular abnormalities that can occasionally be caused by the dopamine agonist. So this person will require echocardiograms every other year. This person will require a lot of close follow-up, and probably will still not be able to fix some of his hormonal abnormalities, such as the hypogonadism, if the prolactin is not responding. So I do think that we are unfortunately looking at surgery in this one of those less than 5 to 10% cases where dopamine agonists do not work.
So some of but those heart valve concerns really only come in at these very high doses. Is that correct?
Correct. 2 to 2.5 milligrams per week and up.
Okay. So you asked me at that point, is there something I can do? And we can see here, the tumor has at this dose actually had a much more reasonable response. You can see a much smaller tumor. It's much more defined. It gives me a lot better target. And I had a very serious conversation about the fact that I wasn't going to cure his tumor because I still think there are some microscopic cells in the edges of this because I know how extensive this tumor was. But I think I can probably take 90 to 95% of this out. Is there value in doing that?
Absolutely. The likelihood of response to dopamine agonist goes up dramatically once most of the tumor volume and tumor burden is removed.
So you would go on a much, much lower dose after that, which you probably should tolerate a lot better.
If you end up requiring it. In macroadenomas, the likelihood of continued requirements for dopamine agonists is pretty high. So I agree that this person might require dopamine agonists down the line, but the doses will be much lower and the response will be much better. And because the doses will be lower, he will be tolerating them much better.
Yeah. What a great example of us mixing and matching our tools together and figuring out something that works for this particular patient. So we did operate on him, and this was a challenging tumor as we expected, but actually felt very good about what we were able to accomplish. And what does this prolactin level mean to you? He's not on Acromegaly at this point. Obviously, it's not quite normal. Is that kind of what you expect to see? It tells us we maybe left some microscopic disease behind. What next steps do we do?
I think we'll just wait and see, trend it out. So over time, the situation will become a little bit more clearer. If it starts going up, then yes, dopamine agonists will have to be reinitiated. But we can make the decision 3 to 6 months down the line.
Okay, fantastic. I'm very, very glad for him, and I'll be watching very closely to see what happens next. Get him back to take care of his nephew. We have one other case, and maybe I don't know if our moderator can help us. Should we try to take some time for questions instead of continuing with one more case, or?
So far, we're good. We don't have any questions. So
okay, great.
If you want to keep going.
So this is a young woman who came to us she had a week of worsening headaches and blurry vision, especially in that left eye. And she had some very subtle changes in her color perception, things like that, but really didn't have any other concerns. And here you can see, and this is kind of a little bit of an unusual looking tumor. We can see it here. It's a little bit of a blob, but it's almost the same color as the brain, except for right in here where it looks a little bit brighter. But all of this was tumor, and this is a little bit of a different tumor. When we look at it from the side, we don't see the typical pituitary stalk or stem because it seems to be completely obliterated by this tumor. We get a hint of it on the backside here. But this is almost certainly something called a Craniopharyngioma, which is a little different, benign tumor. They're really technically more of a brain tumor because it grows more on the brain side, but impacts the pituitary. So the first thing that you guys did once we sent them to you was to check again that lab work to see what the hormone function is like. And that's especially important for these because my goal here, the only thing that keeps these tumors away is a complete removal, but a lot of times that means cutting that stalk or stem and losing function. So what does this tell you about the function here, what you see?
So so this patient's function was pretty normal before surgery. So thyroid function, the TSH and the free T4 were both within normal range. So that tells us that the patient has normal thyroid function. I believe the patient was probably having regular menstrual cycles. So the FSH and LH don't really help us, but if she was having regular menstrual cycles, that would tell us that the hypothalamic pituitary ovarian axis was intact. Growth hormone and IGF-1 levels were normal. And the prolactin level was a little bit elevated, which may be due to the fact that this lesion is impinging on the stalk, and that can cause an elevated prolactin because dopamine from the hypothalamus is not able to get down into the pituitary to keep the prolactin levels normal. So it's not surprising to see a slightly elevated prolactin level in this case. I think what was challenging to us in this case was the patient had low cortisol levels, which usually tell us, especially in the morning, usually point us in the direction of thinking they have adrenal insufficiency. But it turned out the patient had received dexamethasone or an exogenous glucocorticoid or steroid at the outside hospital. And so what we did was we did an ACTH stimulation test and showed that her adrenal function was also intact.
Well, that's very, very important information. So we're sort of stuck with a situation where she probably has to accept some loss of function in order to preserve her vision. So here we can see that she did indeed, she underwent surgery, had a very successful surgery. We tried to leave some gland, but she obviously had stalk disruption. She had diabetes insipidus, and that's where people are, it's called diabetes insipidus because the urine is very weak. It's not sweet, but like diabetes mellitus, but in this case, they're basically peeing out all their water. So what do you do to manage that? How do you manage that long term?
So go ahead, Dr. Mahmud, please.
We have a hormone for that. So desmopressin is typically what we would use. It's a ADH or vasopressin analog, and depending on the severity of the defect, whether they have partial diabetes insipidus or complete neurogenic diabetes insipidus, will determine the doses. But the key thing in the perioperative period is that there is a risk of SIADH or hyponatremia, which peaks between days 5 to 10. So we don't put them on scheduled desmopressin doses. We just wait and see what's going to happen. And when they start breaking through and peeing excessively, we give them desmopressin on an as-needed basis.
It really requires a lot of follow-up, doesn't it?
Yes. But this is one of those things which can actually be protocolized, and I think our nursing care is great in that sense that we only hear about these patients when they are actually meeting the criteria, they are having polyuria, and that's when we hear about it.
And that drug is basically almost the exact same thing as your body makes and seems to work really quite well.
Correct. So in order to enhance its half-life, they changed the structure a little bit, but it's basically the same 9 amino acid long polypeptide, and it works fairly exactly like that without having any other major side effects. The side effect tends to be if you overdose them with desmopressin, they can become overhydrated and hyponatremic, which obviously we want to avoid in the perioperative setting.
It's really amazing when you look, I don't know, 40 or 50 years ago, you couldn't even do pituitary surgery because if they lost this function, we really didn't have options for cortisol or for DDAVP, and it became really life-threatening at that point. So this ability to be able to replace those hormones, I think is absolutely incredible. It's been a big, huge difference for managing these tumors.
Absolutely.
Here we can see how you basically get them on this set of different medications that replaces what they're on and able to treat it to get them back to normal lives. Is that correct?
Yes, after about the first 2 weeks, we can come up with a scheduled dose of DDAVP when we're not worried about a low sodium level. So we can come up with a scheduled dose, and then we can easily replace thyroid hormone. Millions of people have primary hypothyroidism, which is due to dysfunction of the thyroid gland itself. So this is very easy to treat, even though it's due to the pituitary. And we do have patches and pills to replace estrogen and progesterone as well for the amenorrhea, which can develop, or the loss of menstrual cycles that can develop.
Yeah, I always tell them that, at this point, their relationship with you is really the most important. I follow along, I look some pictures from time to time, but really getting this hormone balance right is critical. Does that change over time, or is it pretty consistent?
It's pretty consistent. I think people who become hypopit, for instance, because of a craniopharyngioma and have diabetes insipidus, they're usually on the same regimen for years and years and years, and they get used to it, and they become experts at managing what their pituitary used to manage.
That's great. That's absolutely wonderful. Here we see the MRI. This is 9 months after surgery. We can actually see a little bit of the stalk left here. And this little area, I think, started to show a little bit of growth. And so we actually ended up sending this for treatment with Gamma Knife, which is a focused radiation, again, part of our multidisciplinary center. And that's helped to control this. And it's really excellent for this kind of a tumor where going back in and doing surgery again has potential risk for the vision. So, and obviously people don't want to keep going through surgery over and over again. So we really start to employ all these multitudes. So this person has had an ear, nose, and throat surgeon looking after their nose. They had you taking care of them before, and now really for the rest of their lives. I follow along by looking at the scans and obviously was involved with the surgery. We have the radiologist look at this every time. We have them see an eye doctor when there's something close to the eye nerves like this, so that they're constantly having their vision checked. And then of course we're watching along, and if we need to treat with other modalities like this, we have other options. So this is really how our team comes together, and we have this dedicated team that is all of the different subspecialists. You can see here, how long we've been working together. And there's our surgical team down at the bottom there with our ear, nose, and throat doctors and myself and Dr. Zenonos. And we're really very fortunate to have put all of this together, and that really allows us to take care of these patients, I think, in a way that I'm very proud of, and I think that's very unique and really better, far better than certainly I could do by myself. So thank you for being along with me on this ride and for this webinar as well.
Thank you.
So it
Awesome.
looks like I don't
Thank
see
you
any
so
other
much.
questions.
Thank you so much for your presentation. It was really fascinating. Two questions did roll through, so I'll go ahead and read the first one to you. It is, I am a 33-year-old male, currently have a 3 by 2 centimeter prolactinoma. My initial prolactin levels were at 6,000. My current cabergoline dosage is 2 milligrams 4 times per week. The lowest my prolactin levels have been is 126. Currently my levels have went up and started to take an initial dosage of bromocriptine with cabergoline. Have you had any patients like this? I do not want to take a higher dosage of cabergoline, which is why we are trying both medicines. My tumor size has only shrunk a few millimeters since starting treatment 2 years ago.
It's challenging for us not seeing the scans and not following along throughout the course to make comments about the medical therapy, but I will say that cabergoline has been shown to be better at shrinking tumors and normalizing prolactin levels than bromocriptine. So usually increasing the dose of the cabergoline, even though you're already at a somewhat high dose. I have had patients who are, even though it's not FDA approved to use more than 2 milligrams a week, we have patients on very, very high doses and sometimes do see an effect at those higher doses. I think if there are side effects from the cabergoline, though, that would be a time to take a step back and think about whether you want long-term medical therapy or whether you would consider another option, for instance, surgery.
It certainly sounds like, obviously without seeing the pictures, but certainly sounds like taking out most of the tumor could be very helpful here. But is it true that if even, higher doses for a period of time, if they shrunk the tumor down, then in the future, perhaps those doses could be lowered again? It doesn't necessarily mean forever they would be on those super high doses?
Absolutely correct. So, so I think patience is helpful in this scenario. There are times when we are at these upper limits of the cabergoline doses and we are not seeing the response, and the prolactin has not normalized completely. But given time, sometimes the prolactin can gradually decrease. I would not go up any higher as far as the cabergoline dose is concerned. I don't think that that's going to have much of an effect. If at some point in time the tumor and the prolactin starts to go down, then definitely the cabergoline doses can be scaled back. This is what we typically do, and would we like to see some radiological improvement before we start backing off because we are worried about tumor regrowth if we prematurely start reducing the dopamine agonist or cabergoline doses.
It has to be very frustrating dealing with that and not seeing the results that you want and we all expect, but it certainly sounds like there are great options to try to get that under better control.
Okay, thank you. And our final question is, what is your stance of pan-hypopituitary after a re-resection of recurrent non-functioning macrodenoma?
What are our stats, are they asking, or what's the question?
Your stance, your instance.
Oh, instance, how often, in other words, for recurrent tumors do we lose hormone function with surgery? Overall, our loss of hormone, it's certainly higher with recurrent tumors for anyone because there's potentially scarring, and theoretically the tumor may be more challenging in that situation. There might be some reason why someone would be left behind. But ours is not dramatically different. Our rate overall of loss of hormone function is between 2 and 3% for all pituitary adenomas. It's literature data we've published. And it's more 2% for the first time and about 3% for the redo. So certainly there's a slightly higher rate, but it's not dramatically higher. And we try to keep it about the same. I find there are other things that play into that as well, and I'll defer to Dr. Mahmud and Fazeli, but certainly age plays a role in it. The younger you are, obviously the better you heal and tolerate things. And the size of the tumor is a huge part of it. There are more and more studies that show very large tumors that put a lot of stretch on the gland, a lot of stretch on the stalk, can affect hormone function after surgery and cause hypopituitarism that are as or more important than whether or not it's a recurrent tumor.
Okay, thank you so much. It looks like that's going to conclude our webinar today. We really appreciate all of you taking the time out today to give us this fascinating presentation. We appreciate everyone else taking the time out to join us. If you missed any part of this webinar, or if you would like to share it with family members or friends, it will be available on our website at www.pituitary.org after it's edited. There will be a brief survey after the webinar. Please fill it out to help us provide you with any information you need. Thank you all for joining us, and enjoy the rest of your day.
Our pleasure. Thank you very much.
Thank you.